Welcome to the ONC Tech Forum Clinical Decision Support Series Session 3, Creating Value by Modernizing and Measuring Clinical Decision Support. My name is Tom Deneen with Kaufman and Associates and will be assisting with the logistical support for the Zoom session. To provide comments, please open the chat box, which is located towards the bottom part of your screen. Click on the talk bubble icon. This will pull up the chat box to the right side of your Zoom interface. To ask questions, click on the Q&A button at the bottom of your screen. Please use the raise hand function under reactions and we will unmute your line to verbally ask questions during the Q&A portions of the session. Additionally, we ask that you select speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they share or present information. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Please be aware that today's session is being recorded. The slides and session recording will be available on healthit.gov within a few days. Finally, closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Allison Kemp.
Thank you for joining us today for our third and final clinical decisions support webinar that was part of 2023's ONC Tech Forum. And today's session is about creating value by modernizing and measuring clinical decision support. Next slide, Tom. So I wanted to start today's presentation with an overview of the previous two sessions. So our first session this year in June was what to know about clinical decision support through real-world examples. And in that session, we covered an overview of clinical decision support. We had a discussion on how to implement CDS locally. And then we had examples of interoperable CDS in the real world, which included presentations from the Medical University of South Carolina's implementation of the CDC clinical practice guideline for prescribing opioids for pain, from the University of Washington's Causery and Pain Tracker tool, and from Health Partners Institute's Priority Wizard tool. And you can scan this QR code to be taken to ONC's website, where we have a recording and slides from this presentation and our other presentations as well. Next slide, please. And for our second session, which was the future of clinical decision support, which we held in September, and we covered CDS hooks and smart apps, CDS Connect, patient-centered decision support, the Clinical Decision Support Innovation Collaborative, building co-design, and then we had examples of tools such as the fall tips tools, charts on fire. And then we also had a discussion about clinical decision support and social determinants of health and guideline concordant care. Next slide. And during today's session, we will be covering predictive algorithms and decision support, how new technologies add value to clinical decision support. We will have a few examples of clinical decision support tools, and we will end today's presentation with measuring and evaluation successes in CDS development. And as I mentioned, this is the last session of our workshop series for this year, and we are getting started thinking about what we might want to cover next year. So if you have any ideas of topics that you would like us to cover in future clinical decision support workshops, please put that in the chat, and we will take those into consideration as we plan for next year. Next slide, please. We will start today's presentation with Jeff Smith from ONC, who will be presenting on predictive algorithms and decision support.
All right. Well, thanks, Allison. And thanks, everyone, for joining us in another installment of our Tech Forum. If you could go to the next slide. My name is Jeff Smith, and I'm the Deputy Director of Certification and Testing. If you've not seen this slide before, I think it's a handy base setter for who ONC is and what we do. The three big areas of work that we're engaged in on the Office of Technology side are, and really ONC-wide, is development of standards and coordination of standards. We obviously run a certification program, which I'll speak to in a minute, and then we work on things like TEFCA to promote exchange. Coordination is in our name and is a part of everything that we do, not only with our federal partners at HHS, as well as some of our state and local partners, but also with industry and academia and other interested parties in this space. Next slide, please. So here's a snapshot of the ONC certification program. If you're not familiar with it, it is a voluntary program for software developers to engage in. However, it is a required piece of many CMS payment policies and other programs for use. So while a developer may choose not to certify their software, their users need to be using certified software to get paid. As you can see, we've got about 22 federal programs that reference the certification program. We have made pretty tremendous progress just in terms of overall interoperability, specifically in the areas of patient empowerment. But I think it's really important to note that we see the certification program as a primary policy lever to improve data exchange across settings of care and across a wide range of use cases. Next slide, please. Okay, so a few years ago, and I do mean a few years ago at this point in time, we started to take a hard look at the ways in which algorithms, predictive models, machine learning was being used in healthcare, and tried to understand the state of the art, as well as understand some of the challenges that were emerging with the use of such tools. And I think it's, it's a fairly cliche to think about the blind man in the elephant, but we found that depending on the tool that you were using, depending on your vantage point, you saw different problems, all of them, fairly valid, to be fair. If you could go to the next slide. A different way to look at that same set of issues and challenges, and a different way to look at algorithms in healthcare, is a way that the Government Accountability Office looked at it. This was taken from a report that they issued in 2020. So if you think about where we were in 2020 versus where we are now, not only are we several months past when this report was out, but we have gone through successive iterations and innovations in healthcare and the use of AI. But I think that this is actually a really good grounding way. If we can bring a little bit of sense to the blind man and the elephant analogy, I think this is a better grounding for the different ways that algorithms and predictive models are used in healthcare, both across clinical applications as well as across administrative applications. And these are things that are vitally important to the life and death of an individual patient, all the way to really, really helpful to making sure that clinicians don't get buried in clicks or having to manage a bunch of data that quite honestly don't contribute to the care a patient receives, at least directly. So the same report talked about three big buckets of challenges that they looked at when they were compiling this report at the GAO. And the first bucket was on transparency. And they noted if medical providers don't know how the tools work, it could reduce trust in those tools. They also looked at bias, and they said that there were limitations and bias in data that can reduce the safety and effectiveness of AI tools. And then last, they talked about data and how obtaining high quality data to create effective AI tools can be difficult. So again, this is, 2020. Next slide, please. So not too long thereafter, 2 years after, but I would say early in 2022, early in 2021, we started to look at how to improve the availability and the effectiveness and really optimize the use of algorithms in healthcare. So as part of a pretty broad landscape review, we issued a series of blogs. And I think one of the things that we found was that there wasn't just one challenge. We were tasked early on in the Biden administration by Secretary Becerra to look into how algorithms could perpetuate bias and discrimination. We found that as you start to look into that, bias and discrimination are but a piece of a wider set of challenges and opportunities related to the use of algorithms in healthcare. So this became a framing for a whole series of blogs that we did starting in the summer of 2022. And we looked at this set of challenges as barriers that we need to overcome so that we can optimize the use and the wide dissemination of high quality algorithms in healthcare. So next slide, please. If you were with us and around and watching the Health IT Buzz blog week over week over the summer of 2022 and into the fall, and then into the early spring months of 2023, what you saw was an evolution in understanding and really a framing of a set of issues that resulted in what we proposed through HTI-1 for predictive decision support interventions. And really the objective of a set of proposals that we made public in April of this year was really to enable improved transparency on the trustworthiness of predictive DSIs, really to support their responsible and widespread use in healthcare. And we offered a number of requirements as proposals, and I'll go through some of those. But really the intent of these proposals was first and foremost to improve transparency on the quality of predictive decision support, and specifically on how the predictive decision support intervention was designed, how it was trained, how it was developed, and how it was evaluated and should be used. And we thought that if individuals and if organizations had information related to how predictive DSIs were designed and trained and evaluated and should be used, this would improve trustworthiness. And this trustworthiness would then support its widespread use. We know that trust is a big issue. It's a multifaceted issue, but we saw transparency as prerequisite. It's a building block upon which you can't really do a whole lot else without the transparency. We also thought that we could help support consistency across the industry. There are numerous organizations, especially when you look at where things were in early 2021 and 2022. There are a range of initiatives and efforts and organizations and papers and individuals very much focused on what is the kind of information that would help improve trustworthiness. And we saw the certification program as an important way to create a de facto baseline for information that would be available industry-wide. But we also knew that we didn't have all the answers. And so as I'll go into in a moment, we tried to balance a need for flexibility with a need for some consistency in the information that would be available for a broad range of use cases. And then last, but certainly not least, we looked at our proposals as through the prism of advancing health equity by design. We thought that a key enabler to improving how health equity could be built into the design and development and deployment of these tools would be through requirements for information on whether the algorithm included salient data elements that are related to health equity. We also thought that it would be important to understand whether and how the predictive algorithm was tested for fairness and how the fairness was validated, especially in local settings if that information was available. So this was the broad strokes of what we were trying to accomplish and why we were trying to accomplish it. If you can go to the next slide. This gives you a little bit of a high level snapshot of the logic that we had. So we thought if we could create data transparency on which data elements, especially those that are salient to health equity by design, are used in a predictive model, if we could bring transparency to the performance of that predictive model, and transparency to the organizational competencies of the individuals and firms that develop these models, we could have a demonstrable impact on the trustworthiness of these predictive models. And we came up with somewhat of a cute acronym for trustworthy. And when we talk about high quality, well, what does that mean? We think you can characterize high quality predictive models as those that are fair, appropriate, valid, effective, and safe. And so again, it's kind of through that prism that we looked at establishing a set of requirements. So in the HTI-1 proposed rule, we proposed that developers of certified health IT that enable or interface with predictive models would have to give users information on whether or not race, ethnicity, language, gender identity, sexual orientation, social determinants of health, disability, and age were part of the predictive model. Now, this isn't a judgment. This isn't a question of whether or not that is appropriate to include those models or those data elements as part of the model. But we thought it would be important for users to understand if race was a significant contributor to how the model developed an output. We also thought there was a great need for, as I mentioned, performance transparency. And so we proposed a set of information, and we call these source attributes, that would enable users to understand really the technical and the performance information that they might need for predictive DSIs. And this kind of information, these categories of information, would include what the predictive DSI was intended to be used for. It would have some description of the training data. And as I mentioned earlier, it would have measures of fairness. For those of you who have been following this space for a while, you'll know that this concept of a nutrition label has taken hold, and they call them model cards. Or data sheets for data sets is another kind of instantiation of this concept. And really the big picture that we were going for is, well, we need a consistent vernacular and sense of what the ingredients are that would go into a nutrition label. So we did not propose a nutrition label. We did not propose a form or a format or a manner in which this information needed to be made available to users, but we did propose that certain ingredients that could be used to generate a nutrition label be available for users if they wanted to look at it. We did propose this notion of the information needed to be available via direct display, drill down, or link out. This is actually consistent with our existing requirements for clinical decision support. We proposed that, and again, we proposed it with the notion that we're not forcing developers to flash this information to a clinician unless or until that clinician wants access to the information. So I think that's an important aspect of our proposals. And then last but certainly not least, experience, as we looked at the landscape, told us that there's an important amount of information and work that goes into developing these algorithms before they're deployed. But there's actually a lot more important work, or I'll say a lot of important work additional to, anyway, the work of making sure that an algorithm is fit for purpose for a patient population. And a lot of that work happens post-deployment. When we look at across sectors at how other industries do this, the financial sector is, I think, a really good example of a kind of oversight and regulatory paradigm that puts a lot of emphasis on post-deployment. And they do this through risk management. Obviously, the FDA is working on developing policies, but they're of a similar mind in terms of focusing on how do we ensure that these technologies remain safe and effective after they're deployed. So we did propose a host of what we called intervention risk management practices. And this would essentially require that for each predictive decision support intervention that a developer develops or authors, they would be required to analyze risks and mitigate those risks and deploy and employ governance practices. Now, we relied really heavily on the NIST AI risk management framework for this piece of the puzzle. Again, we know that it would be foolish to get really prescriptive on exactly how to manage risks. But we did follow best practice as it came out of NIST, and we identified several areas, including risks related to the validity or reliability or the safety or the security or the privacy of data used in a predictive DSI. And so that resource, which I think has been roundly regarded as a very positive resource, was central to our proposals in the intervention risk management framework. Next slide, please. Okay, so what does this mean for everybody involved? And again, I think it's important to I think express that we have a very rigid set of policies within the certification program, and we have rigid structures within the certification program that we can leverage to affect change. But we are looking to affect really meaningful change with those rigid structures. And so when we think about why are we doing this, I talked at the beginning of the few slides back on what we intended to have as outcomes of our policies. But I think when we break it down into what is the policy meant to achieve for specific groups, we do think that the policies we proposed, if finalized, will enable patients to benefit and clinicians to use higher quality, more consistent predictive decision support interventions. We know that there has been demonstrable harm by either the misapplication or the correct application, but the otherwise I guess inappropriate use of a predictive model on patients. The literature is rife with this, and we know that this is not in many, or if not most, if not almost all instances, this is not done maliciously. This is done because of the way that the technology was developed and the way it was implemented and used. And these are some of the transparency elements that we're trying to get to. We think for providers, they'll be able to trust the tools that they're using. Again, a lot of the way that we tried to construct this proposal would enable clinicians to look to see if they wanted to, and that would have a pretty important market effect. And we did propose that when information was not available, say because the algorithm had not been deployed in a local setting, the absence of information would be in and of itself a key signal. So we do think that this will have a demonstrable effect on the provider community, the quality of the tools that they're working with, and quite honestly, I would say the overall competency of the user base when they interact with these tools. And then last but not least, we do think that there's some really important kind of developer or industry focused outcomes that could occur as the result of our proposals. I did earlier talk about the ingredients that we're looking to drive consensus on, but I think this will just give the researcher community a lot of information they wouldn't otherwise have access to, or a lot of information that as users of these tools they may not have insights to. And we also think that if we can create the right market conditions where there's less quality uncertainty, those developers who develop high quality models will be able to demonstrate this, and they will actually be able to be more successful in a market that has better transparency on the quality and the performance of their tools. And then last but not least, I think there is the opportunity to create an ecosystem of information that can be used to address a whole host of challenges, both challenges that we know of as the result of research that was done yesterday, challenges that we are finding out of as the result of research being done today, and then challenges as the result of things that we don't yet know about. And we think that a lot of what we proposed is flexible and will accommodate a wide range of use cases and will be useful as technology evolves and as it changes. All right, I think that was our last slide. I think we've got some time for questions, so happy to go through those.
So I haven't seen any questions in the chat or Q&A yet, Jeff, but audience, please, if you have any questions, submit them. And while we are waiting for questions, I was thinking, Jeff, maybe you could explain the difference between CDS and DSI, since both of those acronyms were used in your presentation.
Absolutely, yeah. And happy to tap dance a little bit while people break out the really hard questions. Yeah, so we thought about the reason that we came around to DSI as opposed to CDS was because of one of the things I showed at the beginning, the GAO graphic on there are growing numbers of applications that are not just clinical in nature, but also administrative. And we can think of a whole bunch of different applications that could meet the technical definition of predictive decision support intervention that we offered that are, I would say, in many ways beyond what traditional CDS has focused on, and even somewhat beyond where we think CDS is moving in the future, which is to say use cases that are outside of the clinical application or the clinical use of these technologies. And that was a very deliberate step. I would say two things that are related to that. We offered in the proposed rule a very broad definition for predictive decision support. This was a definition that was not tethered to a level of risk. It was not tethered to a specific use case, and it was not tethered to a specific entity. And that was all very deliberate because once you start to create kind of exclusionary aspects to the definition, then you kind of constrain yourself in ways. And so we looked to craft a policy that was fairly broad in nature. And the other thing I would say is the concept of evidence-based decision support intervention, that phrase, that mouthful of a phrase, has been part of the ONC certification program since 2012. So while I didn't spend a lot of time on it, we did really build on the framework that was established in 2012 in the CDS certification criterion, which you can find in your handy Code of Federal Regulations at 170.315.89A9. And if you look at that certification criterion, you'll see that we really tried to use that as a foundation and build from it, both, I would say, conceptually, but also terminology-wise.
Okay, thank you. And it looks like we have Tama in the audience who has her hand raised. Tom, can you unmute her?
There. Can you hear me?
Yes, we can.
I'm sorry, I didn't. I was trying to write a question instead. Obviously, I hit the wrong picture thing.
That's okay.
So I'm going to apologize some for my ignorance, but I've been tasked with understanding more about DSI, and I am a clinical regulatory specialist. So I work with clinicians and CMS and MIPS and PI and yada, 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 yada. You know, so lots of fun things that ONC and CMS are involved in. And I know their biggest concern are probably the same things that maybe you've heard from Chime is, you know, trying to differentiate what is going to fall under the FDA guidance, where it has to be evaluated more as opposed to something we're working with a demographic right where our organization is. I mean, do you have any insight or inspiration that I can calm them with? So.
I appreciate that question very much. So yes, I would say that we did discuss the interplay at a very high level between FDA's work and ONC's work in this space. It was a message that we received from numerous interested parties, both in terms of just wanting to make sure that there wasn't duplication of effort, and there wasn't, you know, I would say inconsistent requirements or requirements for information that was somewhat divergent or even, you know, kind of in contradiction to one another. I will say that we worked hand in glove with the FDA on our proposals. In terms of coordination and in terms of making sure that they saw what we were doing and had input on what we were doing as the result of proposing this rule. We did this a priori, so before the rule was out, we had a lot of meetings with them, and we continued to discuss with them. So we've shared a lot of the feedback that we've received from you and from Chime and from others regarding this concern. And I can't really go into what we will have to say about it in the final rule here, but I will say that because numerous interested parties did raise this as a concern, you can look forward to having us respond to those concerns in the final rule.
That'll be very helpful.
Yeah.
Because they were just, I think, when I was reading through, it seemed like, at least through the guidance, and the guidance I have from the FDA, I believe, was December 2022, and then copied again in 2023. So as long as I'm not behind,
Yeah.
Was that, the whole point is to give a variety of directions, so you're not just leading someone one way.
Yeah,
So.
well, and I will say, I think we did go into it a little bit in the proposed rule, and just to give you a sense, I think conceptually, we thought that our source attributes requirements for transparency around, the validity and the effectiveness and the safety and the fairness of predictive DSIs would go a long way towards fulfilling some of the same requirements that the FDA would have. I think the important differentiator here is that the FDA is looking at this information and they want to understand it for purposes of safety and efficacy. We're not regulating for safety and efficacy. So even if the predictive DSI said, just by way of example, well, we didn't measure for fairness, or the way we measured it for fairness was we asked one of our employees to look at it and they said it looked fair. So that's what we did. By way of our requirements, by saying you had an employee look at the data the algorithm was trained on and they just thought it looked fair, that would be okay in our regulatory paradigm. I don't know that that would be okay in the FDA's regulatory paradigm, but we did see that there's alignment, and we did seek out alignment between our source attribute information and some of the requirements for risk management along a whole suite of various FDA guidance documents, not just CDS, but there's a few others. And then I will say this: I know that the CDS guidance in particular has had its own set of challenges, kind of divorced from what ONC is doing. But I will say that this notion of independent review, which is in the CDS document, in the CDS guidance, when we sat down to think through, okay, what kind of information should be available to users of certified health IT for predictive DSIs that may also meet the definition of a medical device, what kind of information would plausibly enable a user to say that they had independent review of that technology? And so it was with an eye towards reducing barriers so that a decision support technology that meets the definition of a device, but could plausibly be considered non-device CDS by the FDA's guidance because it provides independent review. Well, our source attributes now provide that mechanism for information that could support independent review. At least that, again, that was kind of the intent.
Thank you.
Thanks, Jeff. And I don't think we were able to have anyone from the FDA attend today, but I reached out to them in advance of this, and they did say that if anyone had questions, to share this email address with all of you. So I'll put that in the chat because they are aware of the relation between both this ONC and FDA work. So I just put that in the chat for anyone who has questions. And then we have a question in the Q&A, Jeff, from Priscilla. When should we expect the final rule?
I wish I could tell you. And I'll leave it there. I'll just say I wish I could tell you, both because I wish I could tell you and because I wish I knew. But I think there has been a few public statements made by our national coordinator. We are very much hoping that as soon as perhaps the end of this year, but we are all I can say is that we are doing our best to get the final rule out as soon as possible.
Okay, thank you. And then we have a couple more minutes if there were any other questions. Let's see. I don't see anything else in the Q&A or chat yet. Jeff, was there anything else that you wanted to say?
I will say that if you want more information, because we covered literally 5 or 6 slides of what was a presentation of probably close to 60 slides. If you go to healthit.gov/NPRM, you'll see a whole host of resources related to HTI-1, our proposed rule. And then if you scroll down, you'll be able to find a fact sheet on DSI, as well as a really very heavy and detailed slide deck that goes through a lot more stuff in detail. And then, if you have any questions, that you'd like to have us try and take a look at regarding HTI-1 and our DSI proposals, please, don't hesitate to reach out. Happy to try and answer them or connect you with the right folks internally.
All right, thank you. And I put the link to that information on our website in the chat for you. All right, thank you, Jeff. I think we have reached the end of our time slot for the predictive algorithms and decision support. So thank you, and we will move forward to the next section of our session today, which is on how new technologies can add value to clinical decision support. And we have 3 speakers, Bryn Rhodes from Smile Digital Health, Dr. Michael Pensina from Duke AI Health, and Dr. Urbaz Riaz from the Mayo Clinic. And they will be speaking about using artificial intelligence to develop clinical decision support and clinical practice guidelines, and how they are monitoring and evaluating CDS that is algorithm-based. And after each presentation, we will have about 30 minutes for discussion where the speakers can ask each other questions and answer questions from the audience and myself. So just a reminder to the audience, please use the Q&A feature, and speakers feel free to answer the questions in the chat while the other speakers are presenting, if that works for you. And then we will also have Lolita Cachet from ONC monitoring the Q&A to help with the discussion after the 3 presentations. So we will now get started with Bryn.
Hey, this is Bryn. Can you hear me?
Yes, we can.
All right. So my name is Bryn Rhodes. I'm a director of standard strategy with Smile Digital Health. I'm also a CDS co-chair, clinical decision support work group with the HL7 SDO. I've been involved in the development of standards and specification for the representation of computable quality improvement for a number of years. I've worked with various organizations and agencies, including Centers for Disease Control, Centers for Medicaid Services, the World Health Organization, on supporting standards-based quality improvement, so including decision support, quality measurement, public health reporting, hospital quality reporting, and really providing a set of specifications that support describing quality improvement artifacts, and then being able to share those artifacts among implementations and consumers. So we've been using integration technologies such as CDS hooks and Smart on Fire to actually integrate the evaluation of these artifacts at the point of care, as well as in population health and quality measurement scenarios. And we've also, as part of that, been developing kind of the category of content implementation guides. So these are fire implementation guides that focus primarily on representing and sharing quality improvement specifications, such as guideline recommendations, decision support rules, quality measure specifications, and all of the content associated with those, like value sets and code system references. And by providing these content implementation guides as platform independent specifications, we hope to move a significant amount of the implementation effort involved in digital delivery of guideline-directed care further upstream, so that the overall effort can be reduced and content and approaches can be reused and shared across institutions and providers. So standards-based decision support and quality measurement, and ultimately standards-based computable guideline content. So one of the significant challenges with this approach is there's a fairly significant learning curve involved in building the standards-based content. Knowledge authors need to know a host of technologies. So you need to know FHIR, you need to know terminologies, you need to know CQL, you need to know the clinical reasoning representations, and there's also a whole set of technical capabilities that a knowledge author would need, such as FHIR implementation guide authoring, familiarity with support tooling such as FHIR shorthand. So there's a fairly steep learning curve involved in building that content. In addition, to really get to quality content, not only do you need to develop the specification, but you need to develop a whole host of tests to make sure that the content is correct, it's valid, it's behaving as expected. So over the years, we've developed a significant toolkit that has lessened that learning curve, and we continue to enhance this process. But the thing I wanted to talk about today is that one thing the community started looking at is the use of AI-assisted development of that content. So instead of looking at how AI could potentially be used in the actual performance of the decision support, looking at how AI might help us actually develop that content and author it. So this idea has already got significant support in just traditional code development. So GitHub's Copilot is an example. It provides developers with AI-assisted code generation capabilities. So they're plugins to development environments that, as you're a developer writing code, you can actually get suggestions and prompt for code that to kind of automate some of the mundane tasks involved in development. So there are several different groups that have looked at how can we take those kinds of capabilities and turn them on this problem of actually developing standards-based decision support content. So in various fora such as connectathons, hackathons, and just kind of shared exploration in the community, started using tools like ChatGPT to help facilitate authoring this type of content. Just in the past 6 months, multiple groups have had fairly good success in these explorations. So asking a ChatGPT basic things like create a FHIR patient resource for a female aged 57. And ChatGPT is really quite good at building that FHIR resource, making sure that it conforms to the specification, and you can coach it from there, say things like post this resource to my FHIR server, all the way up through a fairly sophisticated ask like create CQL that uses the FHIR data model to assess if the care a patient received followed best practice guidelines for diabetes, hemoglobin A1C, poor control. And format CQL to be used in a FHIR measure resource with expressions for initial population, numerator, and denominator. And of course, the initial output isn't perfect. There comes with a lot of caveats and needs review, but with out-of-the-box ChatGPT, these groups have had really good success, and it provides a reasonable starting point. And then with coaching, the output can be improved. And in addition, I think this is one of the more promising areas. Arduous tasks like creating the test cases can be automated. So create a set of FHIR test data to test this quality measure. And you can keep pushing on it, like saying, add edge case testing. And so it will actually do things like create FHIR resources that don't have particular elements to test edge cases. So it's still in early days, but there's a lot of promising exploration in this direction in multiple fronts in the community. And we're looking forward to seeing where that goes. There's a significant learning curve, and tools like ChatGPT can help empower knowledge authors to produce that content more effectively and more quickly. That's kind of what I wanted to talk about today.
All right, thank you, Bryn. And I think I'm slightly jumping ahead, but lots of things you said I think will relate to what Dr. Riaz presents later. And so I think that will lead to a great discussion. So next up, we have Dr. Pensina from Duke AI Health.
Hello, good afternoon. I'm delighted to be here, and I will talk about measuring clinical decision support and the Duke algorithm-based clinical decision support oversight. And I think listening to Jeff's presentation, I'm wondering if we should change the acronym CDS to be broader, because the world is changing, and what started as clinical decision support focus is changing. But I think yeah, that would be a good conversation. So next slide, please. I think we have a wild west of algorithms, right? So I'm personally very, on the one hand, excited, and on the other, worried about the wealth of development that's happening. And that was true even before generative AI came on the scene, where there is a lot of maybe well-intentioned development, but really without the depth of context of understanding of the clinical use cases that these algorithms are supposed to serve, right? So we need to organize the field. We need to make sure that value, quality, and ethical principles are met in what's happening if we're truly going to realize the progress that the technologies do offer. Next slide. And I think in 2020, I published with my colleagues this perspective, talking about best practices for development of, so at the time, predictive algorithms, and going to the sources, right? The kind of Framingham Heart Study work and other areas that develop best practices in this area. This particular paper was written in a response to another publication by a colleague of mine, Ziad Obermeyer, and colleagues, who identified major racial bias of a popularly used algorithm, which used the wrong proxy, right? They were truly trying to identifying the health status and the need for preventive interventions, and they used interactions with the health system, which is known to be biased for disadvantaged populations, and In particular, this algorithm has been shown to be highly biased for Black Americans, right? So we kind of wanted to remind what the principles of establishing solid algorithms are. But the other comment that we put in that paper was that no single regulatory agency can review all the algorithms that will be developed, right? So we do need the right infrastructure, policies, but also the implementation of it for it to happen. And it cannot rely just on the government, right? It truly needs to be in a public partnership manner. Next slide, please. So what are the principles, right? So it's very important to have the right population at risk defined, and how does the population on whom the algorithm is developed matches the population for whom it's applied, right? And that's true for predictive AI as well as generative AI. If you develop it on white individuals, can you apply it to people of other races, right? Whether it's imaging or other algorithms. If you develop it in the certain context of a large language model, does it apply to a situation where the context is different? The second one is the outcome of interest, and that's the Obermeyer identified story, where you have to be very careful with proxies, right? If your outcome of interest and the variable you're using to predict are different, your model can perform poorly and lead to biased results. What's the time horizon, right? How long forward you're looking, and it can be long-term cardiovascular risk prediction. Is it 10 years? Is it 30 years? Because risk doesn't manifest earlier. And it can be very short-term, right? If you have a sepsis prediction algorithm, are you talking about 1 hour? Are you talking about 4 hours? Are you talking hospital stay duration? It all matters. What are the predictors or the variables you include in the model? How easy we can capture them? What's the quality of the capture process that we use? The mathematical model, that becomes interesting, right? We've kind of, at least I was raised on using regression types approaches. Now we have AI at our disposal. I find a lot of companies running into AI and to hide behind the black box and say, oh, I can't share anything because it's too complicated. And sometimes it's not needed. And that's also very true in journal publications, right? Where developers and researchers say, okay, we're using fancy AI technique without proving that it adds value beyond something simpler. Evaluation of the underlying model, the algorithm, right? Global. So that could be a predictive regression-based algorithm, AI-based algorithm, or a large language model that underlies it. And then the translation to clinical decision support, right? And people oftentimes think, oh, it's the algorithm that they need to focus on. It's really not. It's the application. It's the clinical decision support that results. I would say, while it would be unusual for a poor algorithm to perform well, it can be very common that a good algorithm will still perform poorly in the context of a poorly designed clinical decision support. And then the last here is clinical implementation, but it kind of permeates all other of these goals, right? We really need to think about the use case, who will be using it, and will they be using the clinical decision support that we're putting together. Next slide, please. So at Duke, we created ABCDS out of primary focus on patient safety and high quality care. I think this is based on our practical experiences, right? Where our health system was not ready to address the deluge of algorithms thrown at us, primarily from external vendors, but also our internal researchers. And we said, okay, we need to have some order here, right? We need a sheriff in this Wild West setting. So that's why we put it together. We worked with our health system leadership, who made a commitment that no new algorithm will be applied to Duke patients until it goes through a review process that we designed. Next slide. And the design is here. It's based on what the FDA does with medical devices, right? There are 4 stages. That there is the development stage, which is kind of the pre-human development. Then we have silent evaluation, which is kind of the first in human phase, and then the effectiveness, the pivotal trial, and then the general deployment and monitoring. And you see these green gates in between. So after every phase, there is a review by our ABCDS committee and a decision if the algorithm is ready to move to the next phase or if it needs to go back. And again, this is not really a review of the algorithm per se. It's a review of the algorithm trying to solve a given clinical use case, right? So if you have one algorithm for one use case and you want to use the same algorithm but for a different use case, you would have to have a separate review. And critically, right, there are the GM different gates, so that refers to regular monitoring. And the evaluation happens, and there is also, we ask for registration of the algorithms, right? So that's really, really important to us, because I strongly believe that transparency starts with knowing what we have, right? On the health system level, my kind of big dream is that every health system will register all AI tools that are running, because I can tell you from experience, when we started ABCDS, where there were so many different algorithms in different pockets of our health system, which is not even that huge, right? That nobody was aware of, or only the local groups were aware of, right? So the registration is critical to really know what we have. And I think registration should apply to the clinical, but also the operational. We need to know what's happening. And I would like to have a patient-facing interface, right? When we have a patient who is concerned about what AI is the health system running in the background, that they can go to a website and really see what AI is being used for by their health delivery provider. Next slide. Right, so it's a process. We have a committee and 3 subcommittees. One is regulatory, one is evaluation of the algorithms, and one is implementation and monitoring. I would say the regulatory is very important, right? I think the regulatory framework is happening as we speak. I think the question to Jeff, we're waiting for more guidance in this space, and there are open questions. Like, for example, if we turn on an algorithm developed by a large local national vendor, is that on us to make sure it performs, or is it on them, right? Who makes the determination? Right now, because we have the ABCDS process, we're able to, we will evaluate them, and we have a very, very rudimentary simplified process with registration and checks for FDA-approved algorithms in place. But those are important open questions. And also there is the kind of health system equity level question. We realize that many health systems will not have the cadre of people ready to do the work that Duke has, right? How do we scale the oversight on a more national level? And I think that's a huge opportunity to partner with ONC, FDA, and other government agencies to really take a national view here. Next slide. Right, so this is showing that our process was not just an academic exercise. We identified 62 tools at different stages of development. And again, the focus was on the ones with primary clinical applications and kind of going a little bit kind of the clinical operational, right? So we have one that predicts the duration of surgeries for better scheduling of operating rooms. And so that's kind of in between, but we said that's in scope. I think with large language models in place, we're realizing that we need to expand ABCDS into operational AI use cases, because we need to have some form of oversight for these tools as well, because they can create bias or adverse consequences. Next slide. And importantly, right, this is a Duke example of making the world better locally, but we want to make the world better also on the national stage. So we joined forces with colleagues from several other institutions to form the Coalition for Health AI, which intends to take processes like the one I described and develop national standards in close partnership, again, with the government, ONC, and others, that this is not a kind of health system specific fragmented approach, but really national or maybe larger. We're having conversations with colleagues in Europe right now and seeing, can we align on standards for algorithmic evaluation, governance, and monitoring, right? So we published the blueprint for trustworthy AI, which takes the NIST framework, the White House document, and translates it into healthcare. And now we're working on next steps of making it more concrete, that health systems can take it and use it. And it's work in progress. And again, we appreciate it. ONC being an observer and partner in this effort. So I'll stop here, and I look forward to our discussion.
Great. Thank you, Dr. Pensina. And next we will have a presentation from Dr. Riaz from the Mayo Clinic.
Okay. Can you hear me? And let me just share my slides and then we will get started. Okay, can you see my slides now?
We can.
Okay, perfect. So good morning, good afternoon, depending on where you are. My name is Irbaz, and I'll be talking about living interactive systematic reviews and clinical practice guidelines. I have more slides than I'm going to cover, but I kept them in the slide deck because we have a discussion after this and some of them can be used for discussion. So, as clinicians, we rely heavily on clinical practice guidelines as we take care of our patients. So when we see our patients, often what we need to do is we need to pull up the latest and the greatest clinical practice guidelines so that we can provide patients with guideline concordant care with the most up-to-date evidence. So good clinical practice guidelines are built on high-quality systematic reviews and meta-analysis. Doing good systematic reviews takes significant expertise. They're time-consuming, they're painstaking, and it needs a teamwork, so they can be expensive. The challenge with rapidly moving evidence, for instance, I'm a medical oncologist, and in cancer arena these days, the evidence is evolving so quickly that our systematic reviews or clinical practice guidelines are outdated very quickly. And often, when a new systematic review is done, the updates start from scratch. And there is no use of technology, and there's a lot of wasted effort. I'll give an example. But before I do that, I'll talk about a usual workflow of systematic reviews and making clinical practice guidelines. First, evidence is searched from published literature using databases like PubMed, using Ovid or Medline interface. Then the relevant data is screened. If we decide that, oh, this paper is relevant to the clinical guideline of interest, we extract data, we analyze it, and a clinical practice guideline is then created based on that evidence. So I'll give you an example. There was UNESCO guideline on prostate cancer treatment. In 2019, there was the first update of that guideline. We went through the guideline process and, it was all done. The project was complete. But, there was a time later when we needed a new update. At this time, we started again from scratch. We started with 10,000 citations. Now, because the evidence had grown, we did the same steps of screening, extraction, analysis, guideline development. And now again, we need a new update. And now there's much more bigger evidence body. And now we'll repeat the same process again to kind of mostly from the scratch. And you can imagine how redundant this process is and, how much wasted effort, this process kind of sees as we do it multiple times. So instead of this workflow, what we have tried to kind of, is reduce redundancies and introduce technology in this workflow so that we can create the clinical practice guidelines, which are almost updated, which can almost be updated in real time. And you can also use the evidence for many downstream things like interactive decision aids, algorithms, evidence profiles, and hopefully this can also be integrated in electronic health records. So this is a specific example of the project we did. The first iteration of this guideline came in 2017. Evidence was searched, screened, data extracted, systematic review was done, and the paper was published and a guideline was produced. However, new studies keep coming, and one would hope that somebody is watching the new information seamlessly. And once the new information comes, that information just goes through this workflow of screening, extraction, record is maintained, analysis is done, and if needed, the downstream steps are updated. So this is exactly what we try to do here. When the new for this particular project for castration-sensitive prostate cancer, when the new studies came, we were able to identify the new studies, and they went through this pathway of systematic review and guidelines development process. And we also, when we create living systematic reviews, we update in a living website, because publication process is slow. It has to go through peer review. So we have this non-peer reviewed website that accompanies all of these living analysis, which are updated in almost real time. And then all the downstream products, so to speak, can also be updated. And this process can go on, and there are new studies, and we updated the process again. So with this workflow, what we could achieve is these what we call living systematic reviews and living clinical practice guidelines. And often the question comes that when do you publish them actually? So for each clinical question, we have a clinical expert committee which decides that when there's enough evidence change that we trigger a publication. For instance, for this project, once there was an update in 2022, we published in JAMA. So how do we enable this? I think I was asked to kind of focus a little bit on the process. Some of those things are very simple. They don't need fancy machine learning. Others are a little bit more complex, still pretty hard to do. The watcher module is kind of built on a simple natural language processing push and pull retrieval system. Screening is more like the bigger AI models. We are moving towards large language models to screen the relevant citations now. And same thing for data extraction. We started with very simple machine learning annotation models when we start the process. But, just like everything we have these days with the introduction of large language models like GPT 3.5, GPT 4, Llama 2, etc., we're now experimenting with those models to extract the data automatically. And, the results are pretty fascinating. And analysis is basically based on standard R pipelines, and those are fairly easy to automate with rule-based algorithms. So each step is basically we kind of thought about each step in the systematic review and developed an informatics infrastructure, some of which uses machine learning and AI and modern large language models to complete the process. So each step is kind of built on a modular basis. So watcher watches evidence, screener screens the new evidence so that we can ensure that the right citations are included in a particular analysis. Then extractor model extracts data, analyzer model analyzes the data, and then the CNA models kind of to design those CNAs to interact with the patients. At this time, because we are using this for clinical practice guidelines, we want to be perfect. We have a human in loop in each step to make sure we have fidelity, and we're constantly looking at the performance of these models and make slight iterations in the process in terms of where we can rely on automation, semi-automation versus completely a human in loop is necessary. I'll probably skip these slides. I just want to go to some of the presentation of the results, because the second piece of our work focuses heavily on the presentation of the results. So we have living evidence, and we also have interactive evidence. Interactive evidence is pushed on our website, and on website, we create standardized tables that can summarize the data. In static tables and figures, there are lots of tables that you have to look through to find the right evidence. So basically, because they're extracting data, we create a menu for users where they can just focus on what they really want to see. They can kind of click these buttons and create the table they care about. So database exists at the backend from the data that is extracted as a part of meta-analysis and the process of clinical practice guidelines creation. But users can kind of interact with the evidence and just focus on the evidence they really care about. Similarly, for analysis presentation, we have forest plots, and they're organized in a fairly standardized categories of primary analysis, sensitivity analysis, subgroup analysis. You can kind of click on all of these buttons to see where you want to focus and interact with. For some more complex analysis, like network meta-analysis, where we have to make indirect comparisons, often in oncology, what happens is clinical trial was done for treatment A versus a reference treatment, and then for treatment C versus the reference treatment. But in practice, you have to decide between treatment A and treatment C. So there is a statistical model that is called network meta-analysis that allows you to make those comparisons in a statistical framework. And we need standard structured clinical output for guideline makers to kind of look at evidence. So we have created those tables and figures, and guideline creators can interact with these tables and figures on the website. And then we have summary of findings table, which kind of outline all the endpoints of interest for a particular guideline. And then we have relative and absolute magnitude of benefit and toxicities listed in all one table. And then we kind of create an evidence map of where the evidence is coming from, where the gaps. I haven't shown here, but what we also do is we create then the CNAs so that patients can interact with this evidence in a more patient-friendly format, because the figures that you have right in front at the moment, or the the network meta-analysis plot, they can be very complex even for clinicians, so patients cannot really gain any meaningful information out of that. So we think that with our approach of living interactive systematic reviews, we can truly enable living guidelines with real-time updates, almost, I should say. We can we do a lot more with available resources, really double the output, just put wheels on this big box, so to speak. We can maintain the same rigor and agility that is required for clinical practice guidelines for taking care of patients, because we have rigorously tested the algorithms at each steps we're using, and we have still human in loop for most of them to make sure we're doing everything which is pristine in terms of the fidelity of the analysis. And in the next step, what we hope to do is we want to standardize for EHR integration and downstream efforts such as evidence summaries, shared decision making, aids, and algorithms. The hope here is that we can, create a complete workflow where evidence is synthesized, using assistance from AI, with humans in loop, standard algorithms, and then have updating of downstream practice guidelines, patient decision aids, interactive algorithms, all updated almost in real time. I want to acknowledge some of my colleagues and my co-fellows who have helped throughout this process. This work wouldn't be possible without their help, and I'll be happy to take any questions and answers after the presentation. I think we're almost done with time. I'll stop sharing here.
All right, thank you, Dr. Riaz. So now for about the next 30 minutes or so, I would like to have a discussion with the three speakers that we just had present. And we are happy to accept any questions from the audience. So feel free to put your questions in the Q&A box. Or if you were interested in speaking, you can raise your hand and we will bring you off mute. And so I guess I wanted to get us started with a question about the value of using AI in clinical decision support. And so like what value do you think AI can bring to CDS based on all the information the three of you just shared that like, more traditional methods of CDS don't have?
So are you asking what's the value of AI on top of what we could have done with CDS in general, or value of advanced technologies in general?
I think both.
Both. Okay.
Yeah.
Okay. Very good. So I think the potential is tremendous, right? So there is no question in my mind, and we are getting a lot of interest. And I would say, as I was commenting my presentation on the operational piece, right? So I think what in the earlier session, what Jeff said about the renaming CDS really resonated, because it's almost like the world shifted a little bit, right? So pre-large language models, it was a lot of clinical applications interest, and I think people were going with the operational, but not as much. And then it seems in the last year, it's a total shift to the operational applications. And I think your question of value is really important, because I will say it has not been well articulated, right? So it's in the potential sphere. We believe it can lower the burden for clinicians, nurses, providers. It can improve care delivery, but I'm not aware of a good model that can be applied early on, right? Kind of a health economic model to say, okay, if I implement this AI-based strategy, what is the additional value that I will realize, right, in terms of return on investment, return on health, whichever metric you're trying to use. So that's the kind of general answer. The AI versus existing technologies, I will say, for large language models, voice recognition and imaging, absolutely, right? We did not have the technologies that could do what can be done today. So I think that it's kind of going almost from zero, or from crawling to running. On the predictive space, right, apart from imaging, kind of structured data, the value of more complex AI-based methods compared to more traditional regression-based is the added value is very low, if anything, right? So it's really having a solid model well implemented in the workflow as a clinical decision support. And in our experience, it doesn't have to be too fancy to perform well.
And I can speak from a guideline perspective. I totally second Dr. Pensina that, there's tremendous value, but we haven't really thought very well about how to quantify that value. For instance, when I work on guideline panels, or, develop the systematic reviews to collate evidence for guideline panelists, it is a tremendous amount of effort to look through all the literature, identify the right studies, extract data from them, and then analyzing that. And large language models are really good at, text data, right? Especially the bigger, 1.75, 2 billion parameter models. They can do a really good job at, reading through a paper and telling, whether this paper is relevant to a prostate cancer, guideline or not. So they can really kind of lower the burden of the work that we typically do to kind of collate these evidence summaries. So I think that's where we are trying to use them. And, as we improve, so in the past few years, we were trying to do this, but models were not good enough. Now, with the bigger models, the performance is much better. So I think that now it is a reality where we can use these models to actually do the steps in synthesizing evidence. And I guess obviously we could do cost effectiveness analysis to kind of see what's the value of that, but we haven't really thought about that too much. So there is clearly a perceived value, but we haven't really quantified it.
Bryn, did you have anything you wanted to add?
Yeah, I would just echo. I mean, there's we've, like I mentioned, we've seen the effectiveness there of the newer models. They're really quite good at taking the data that's available on the web and synthesizing it into something that really takes a lot of the legwork out, and you can see pretty quickly where that would just assist developers at every step of the process. So we're excited to see where that goes, because I think there's potentially a tremendous amount of value there. Of course, don't have it quantified, but it certainly seems to be there.
And Bryn, I was wondering what you were thinking of Dr. Riaz's living guidelines model, with knowing that you've done so much work with the CDC guidelines for prescribing opioids, and how updating those from the 2016 to the 2022 guidelines, how much work that has taken, and if there was a way to do it, like those updates the way that Dr. Riaz was prescribing, like how do you think that could change making those updates?
I really, that was a really exciting presentation for me. That was, I think the key would be for me is the ability to tie it back to the specific evidence that's relevant for the recommendation you're representing. And it really getting to the point where you're understanding what changes impact what recommendations within a guideline. In the update to the 2022 content, we were able to do that fairly quickly, but that was only after all of the effort that had already been undertaken by the CDC group to build the guideline, and the potential for that guideline to come with more detailed, more structured information about where the evidence came from and what recommendations are actually impacted, I think has a tremendous potential to speed up that process, right? If you can better understand the dependencies, you know better where to focus your updates. And getting to the point where you've got structured representation of that evidence, really, I think would be really, really valuable to the decision support and quality measurement space. I'll also say, I don't know whether you've seen any of the evidence-based medicine resources within FHIR, but there has been significant effort and work on representing things like systematic review, summary of findings in FHIR as a mechanism for exchanging that information. So that might be interesting to look at, whether there are some ways that you can actually use then standards-based approaches to support representing that information and disseminating it.
Great, thanks, Bryn. Dr. Riaz, did you have any responses to what he just said?
Absolutely, this is a good comment. I think we one of the things that you mentioned, we make a point of having a structured representation of everything we do, so that everything is transparent. Because with clinical practice guidelines, what you really want is transparency, right? You should be able to kind of see, where did the new evidence come from? What decision was made for each particular citation? What data came out of each publication? And this is exactly what we focus on. And this is why when I said that it's both rigor and agility, that's important. So that's the rigor piece that you mentioned. We have been thinking about how to make this FHIR compatible. I mean, we have everything structured, but we haven't really thought of it in terms of standards. And I think that's clearly the next step, because that will allow the next steps more seamlessly, like, for example, integration in EHR, and also sharing of information with other platforms.
And then something you said, I'm going to tie to Dr. Pensina now. So I was wondering how, when you're reviewing the algorithms in the ABCDS process, are like providers, when they use that CDS, able to see like where the evidence is coming from? I'm thinking back to the transparency that Dr. Riaz mentioned, and then also that Jeff mentioned in his presentation earlier of, is there like a report provided or how do providers get to see what's happened in the evaluation that you've done?
Right. So we work with the teams, and part of the ABCDS process that really helped us is define the roles of different groups, right? Because it started with the algorithm, and there was always a human somewhere attached to it, and kind of main user and responsible party. So we have a fairly detailed intake process that gives us the information, right? Kind of following the principles are outlined, and some of the work related to data cards that Duke has published. So we have that intake, and then the evaluation proceeds with that. We are working on building a registration portal that would enable us to make that information visible, right? And that's visibility for internal health system consumers who are interested, as well as patients externally. Right now, we don't have that functionality, right? So if somebody came, we will share the information, but we don't have that transparency engine built yet, and it's more of a kind of technological limitation at this point than anything else, right? Because the concepts are there, but it's not ready yet.
Okay. I think that will be an important piece to have later.
No, absolutely.
Design,
Yeah, that's exactly on the roadmap. So I think you're spot on, right? Because it's as I said, transparency starts with kind of cataloging what you have, and then making that information available to the stakeholders, which exists in the health system and outside the health system, right? And kind of taking the national view. Imagine if we could link all of those across the different users, right, and have a national repository. I think that would be a tremendous resource. I'm kind of thinking of clinicaltrials.gov as an example, right, of a structure of this kind, where if you have interest in a particular study, you can go and find it there. So something similar for algorithms for specific use cases.
Okay, and I'm thinking then next for all of you, how would someone who wants to incorporate any of these different tools be able to use them? So if someone in the audience said that they, wanted to institute their own version of the ABCDS at their institution, or if someone else wanted to start having living guidelines working, or if someone wanted to use ChatGPT to help write code, how would someone go about doing this? Like, what's the next step for them?
Right. So I can start with ABCDS, right? So we've published on what we're doing, right? So it is in the public domain. We're also delighted to consult and work with interested entities. I will say that's not enough, right? So Duke has partnered with Microsoft recently to start developing the technology that will enable ABCDS, kind of, we call it governance as a service, right? Because I do realize, and I would say even the technology that we're using is fairly antiquated. It's not smooth, right? I kind of say ABCDS is a people process technology approach. We have great people, we have good process, we need better technology, right? So we're starting to work with Microsoft to automate some of what we're doing. And if you can imagine, if we create a kind of registration governance portal that can be shared with different health systems, but it needs to be built in a clever way, because I'm the first one to admit, I don't think every health system would want to implement ABCDS exactly the way Duke implemented it, right? So we have to build it in a way that enables flexibility. But if we do that, right, since there is a menu of options that's customizable, I think that would be that would be an asset. And then you add the humans where you want to specify the process as you want it. And I think it can be applicable. So again, Alison, again, you were raising an excellent question, and we are thinking and planning, but it's not ready yet.
Okay. Dr. Rios?
Yeah, no, I think that's a great question. I think it's still a process. It's a very involved process because, if you're thinking about a clinical practice guideline, first it has to be consensus on the important questions, then a consensus on the process, and then, a workflow for technology, and then humans in the loop to check, make sure technology is working fine, and then a draft by the disease specialists who work in the disease group. So it's not something that you can just do independently. I think it's still a teamwork, a process, and it takes a lot of time to kind of get the process right.
And Bryn?
Yeah, I mean, I think if you're in that space of building FHIR content implementation guides, you can pretty easily just jump into a ChatGPT session and ask it to start, building new content, especially FHIR resources. It's quite good at just building like the JSON representation of a FHIR resource. And that there's a lot of legwork involved in building like unit tests for all of the content you're creating, and ChatGPT can certainly help with that. We have folks using it already to kind of help build out those test cases. As far as anything, more formal than that, as I mentioned, there are several groups within the community looking at ways to like start with a ChatGPT that's been prompted and trained a little bit more on specific content, but nothing currently available. You can jump on ChatGPT and start playing with it, but we have I'm not aware of anything currently more developed than that.
Okay, thank you. And I'm surprised our audience is so quiet today. So if anyone did have other questions, please feel free to put them in the Q&A or raise your hand.
Alison?
Yes.
Real quick, there was one question in the chat, and this is for Dr. Riaz, and someone asked, is there a live interactive link for the lit review effort?
Sorry, I was muted. Yes, there is. So some of these are already published, and each of them have a companion link in the publication. I can email that to Alison after the presentation, and she can forward.
Okay, yes, I can do that. And then maybe Juan May, if you wanted to send either Lolita or I your email address, we can get that forwarded to you. And then let's see. For another question, I was thinking about how do we know if we are making progress in using AI, if we are like making sure it is more equitable, making sure it is actually being helpful, that it's providing correct information. How can we monitor the AI to know that it is truly providing value?
So I will tie it back to use cases, right? So I think the national value pattern will emerge based on successful use cases, right? And again, we can look back to attempts to bring AI and technology to solve problems 5 or more years ago, and many of them failed, right? There are high-profile endeavors that are no longer in existence as such because they were not able to demonstrate that they solve pressing problems. So I would tie it very strongly to use cases. It's totally not, it does not persuade me to see an algorithm with a great AUC, or I look at I recently saw GPT taking SAT examination, right? And I was looking at it kind of with interest, and because my daughter was taking SATs as well, and I was comparing her performance to GPT performance, but more as a kind of humorous comparison, kind of having a discussion of how good it is. But that's not what I will want GPT used for, right? It's completely, it's interesting, and we can correlate it to its future ability. But GPT taking SAT, it's a pretty useless use case in of itself, right? If it's predictive of something else, there might be value. So it needs to be tied to solving real clinical problems, right? And I'll pick on one, which is the ambient text recognition and clinical note creation, which that's one area that everybody's excited, right? When I talk to friends and family who are kind of very worried about AI, when I come up with the example, so do you go to the doctor? Yes. How much time do they spend talking to you versus on the computer? And say, well, not enough talking to me, right? If there was a way to simplify their jobs, would you be okay with it? And everybody says, yes, that would be great. And then the doctors or nurses says, yes, we want it. It would be great. I think there is an estimate coming from Duke that a nurse spends 3 to 4 hours in front of the computer a day, right? That's not sustainable. That's not work satisfaction. That's not what they want to be doing. If we can simplify it with the use of technology, it's a real win. And I would say, I think the measure then becomes the reduction of time spent in front of the computer, more time spent with the patient. We can measure the burden reduction, right? Satisfaction of nursing and clinical staff, as well as patient satisfaction as the measure, right? And so that in this use case, that would tell us AI is working. But I would say we have to tie it to specific use cases, and we have to solve them, not just show the potential.
And Bryn or Dr. Riaz?
Yeah, I can comment here. I think it's Dr. Benzina put it perfectly. It's about the use case, right? So I'll just go back to the guideline process. If I could do the same, I could have the same staff, and we could create 10 guidelines with the same staff before we were doing 3 or 4. It's a win, right? If you look at a more like patient setting example, these institutions like Duke, like Mayo, we spend a lot of time, effort, money, finances in structuring clinical data from unstructured electronic health records, reporting for cancer registries, for quality, for research. If the generative models can extract the data and we have one structured data work stream which can feed into updating cancer registries, clinical decision support, matching to clinical trials, several downstream uses. I think that will be amazing. I think it's just the fact that what we don't have at the moment is a good idea of how much it's going to take for us to build those algorithms, deploy it, at a hospital level system, and and how much we're going to save by doing that. So I think the cost effectiveness, it seems tangible, but you don't know until you have done it. And all of these isn't happening now, so we'll have these answers soon.
Okay, that's great to hear. And Bryn, did you have anything to add?
I would just echo that it's got to be based on the use case. And I mean, if you're talking about the knowledge authoring case, can you be more productive? But I think the real kind of, whether it's being effective is really just kind of a recasting of the larger question of whether CDS is effective, whether it's a AI algorithm or not. How do you get to the point where you can demonstrate and show effectiveness of the decision support? I don't, I know that there's a significant effort there. And I think if you have, you have that kind of outcome demonstrated, whether it's an AI algorithm in the decision support or not, it's kind of black box from that perspective. You really need to say, is the decision support improving the outcome that it's supposed to be?
And that's a great point, Bryn. And I'm hoping that all of our examples and presentations for the second half of today's presentation will cover that. We will have a few examples of tools that are using smart apps and AI, and then also have a few presentations from or that are about research showing whether or not their CDS has been effective. And we do have a question in the chat, and I see Dr. Pensina, it looks like you're answering it. Was there anything that you wanted to say?
Yeah, I would just
Yeah.
quickly what answer. The question is, what drove Duke to establish the ABCDS process? And I would say it was a real need that was realized in our health system, right? The health system was not ready to respond to the AI algorithm revolution that was happening kind of to us with different external and internal vendors developing these tools and saying, okay, this is great, it works well in this health system, you need to try it here, you need to buy it from us, right? Or a researcher saying, oh, I just got a grant, I have this great algorithm, please implement it, and didn't know what to do with it, didn't know what the value right and implications will be, and that's why we put together ABCDS. I will say the publication I mentioned, the Obermeyers, with the bias that can result if we don't have the right structure, was also a kind of very important wake-up moment, which we used in conversations with health system leadership.
All right, thank you. And I believe we have now finished our half hour, and I really appreciate the discussion that we had about AI and using this technology to develop clinical decision support. And so now we will transition to a break for 10 minutes, and we will be back at 1:51 Eastern time. So thank you.
Thank you.
Tom, can you hear me?
Yes, we can hear you, Ken. Thank you.
Wonderful, thanks. Can you hear me now?
Yes, we can hear you. Thank you.
Thank you so much. I'll go back on mute until needed.
Thank you.
Thank you for attending our presentation so far today, and we are going to get started again with a few examples of CDS using AI and smart technologies. And so first we will have Dr. Kensaku Kawamoto from the University of Utah present, and then that will be followed by Dr. Nathan Dean from Intermountain Health and the University of Utah. Ken, if you're speaking, you're on mute. So it looks like we may have lost Ken. Oh, no, I see he's here. Ken, are you back?
Ken should be able to unmute himself and turn on his video. I'm not clear on what's, if you're having trouble, Ken, please go ahead and drop off and then rejoin using the same link in the calendar invite.
And Tom, while we wait for Ken, perhaps we could move forward to the second group of slides. Yes. Yeah, Dr. Dean, will that work if you start
Sure.
first? Okay,
Sure.
thank you.
Yes, thank you for the invitation to present today. Next slide. So I have no conflicts of interest. Our work at Intermountain is supported by 2 HRQ grants, as you can see. Next slide. So we've been working for years on e-pneumonia clinical decision support, which has a number of key functions that I wanted to describe here. First of all, it screens emergency department patients in real time for whether or not they might have pneumonia. It checks ED artificial intelligence for checks X-ray images as soon as they're uploaded, plus Bayesian probabilistic algorithm that uses 40 data elements to estimate the likelihood of pneumonia. And then on the electronic tracking board in the emergency department, once the diagnosis has reached a 40% likelihood, it prompts the bedside clinician to enroll in this decision support tool. It then calculates severity of illness and then recommends site of care based on that stratification of inpatient versus outpatient care and ward versus intensive care unit. It uses a number of factors, include an electronic version of Curve 65, a measure of oxygenation known as the ratio between the PaO2 and the delivered oxygen, severe CAP criteria, and whether or not the patient has a significant sized pneumonic effusion. It then identifies risk factors for resistant pathogens using a 10-factor DRIP score, which is electronically calculated. and then recommends emergency department administration of antibiotics tailored to the site of care and the likely pathogens. Linked with that, it recommends appropriate microbiology studies. All of these are consistent with the 2019 ATS IDSA community-acquired pneumonia guidelines. It is open loop throughout, meaning that it allows for clinician judgment, the room to opt out, disagree, and provide their reasoning. Next slide. This is an example screenshot. The e-pneumonia clinical decision support tool is currently running live in 22 emergency departments across Intermountain, embedded within our Cerner electronic health record. And this is an example of what the clinician sees on the front line. These are the 9 severe CAP criteria. The abnormal ones are highlighted in pink. The tool makes a specific recommendation, and you can see above that recommends ICU admission based on needing ICU treatment with those criteria. The box is pre-checked, and all the clinician needs to do, if they agree, is to click on the Save button. If they instead click on the Disagree with recommendation, a pick list comes up, as well as a free text box that they can put in their reasoning. And at the end, all of this data collected by e-pneumonia is put into the clinical report, the emergency department physician note, the admission physician note. And if they disagree, the reasons for the disagreement are also put into that note. Next slide. So we first looked at the performance and outcomes of e-pneumonia in a publication in the Annals of Emergency Medicine, which is the primary emergency department journal. And what we did was in 2011, we rolled out e-pneumonia, deployed it in 4 hospitals in the Salt Lake Valley here in Utah. And left 3 other hospitals along the same urban corridor we call the Wasatch Front as usual care controls. These 7 hospitals had about the same mortality during the baseline year, but when we compared 30-day all-cause mortality after we had deployed e-pneumonia, you can see a statistically significant drop of 2.6% absolute mortality at 30 days. Next slide. So based on these positive results, once Intermountain Health had unified its electronic health record using the Cerner system, we deployed this across the rest of the hospitals that were part of Intermountain Health in Utah. The emergency department leadership support was critical to this, both system-wide and at each of the study sites. There was emergency department clinician engagement, importantly, in tool development and deployment from the start. Went around to these hospitals and we had interactive educational meetings with the frontline providers. Local champions taught and encouraged use of e-pneumonia. We tried to identify at least one provider at each site who was a super user and helped encourage use within their own site. We had a nurse educator who was an emergency department nurse who visited clinicians during their shifts to teach and encourage use of e-pneumonia. Importantly, we did audit and feedback, reviewing notes and feeding back utilization rates and observational parts that we, how should I say this, observations based on the clinical notes, whether the e-pneumonia seemed to be impacting their clinical care in positive or negative ways. We also familiarized hospital admitting physicians with e-pneumonia to smooth transitions of care. And interestingly, this was one of the most popular parts of e-pneumonia for the frontline clinicians because it saved them a lot of time and stress when they were interacting with the hospital admission physicians as they were admitting a patient. We published in 2 different journals the deployment methods, and these are descriptive papers. Next slide. So this was a stepwise rollout over these hospitals. And you can see this went from February of 2018 to December of 2018 and measured the utilization based on review of clinical notes at regular intervals. And while there's some up and down, you can see that basically over time, the different sites gradually increased their use of eudaimonia, although there was site by site, cluster by cluster variability in the uptake. The one cluster that we had the least amount of uptake were the rural sites. And in retrospect, the tool was not very well designed for these small rural hospitals that we have at Intermountain compared to bigger hospitals with emergency departments. About 2/3 of patients overall during the study period had eudaimonia run by the clinician. Next slide. So we published this as well. This was about a year ago in the American Journal of Respiratory and Critical Care Medicine. And interestingly, our results were very similar to the prior study. These were different hospitals and a stepwise deployment. The mortality difference absolute was a little bit larger. The adjusted odds ratio was about the same. Again, a significant reduction in mortality after deployment of eudaimonia. Next slide. We also had other positive outcomes in terms of processes of care. We had a 17% increase in safe home care, safe home disposition in patients diagnosed with community-acquired pneumonia. And the patients who went home had a low mortality rate. The rate of them bouncing back into the hospital within 7 days was unchanged. Antibiotics were initiated a little bit earlier, and they were also more guideline consistent, narrow spectrum, again, consistent with the national guidelines. About a half a day decrease in median length of hospital stay. Next slide. Having gone through this work for years, we recognize that one of the limitations and challenges in our eudaimonia decision support was that technically we were getting the radiology information, having to wait for the radiologist to dictate their report, which most likely was free text, most commonly was free text, and then applied natural language processing using the NLP program that is built into Cerner. Next click. So we have switched over to artificial intelligence imaging analysis and abandoned the NLP methods that we used during those two papers. Next click. And doing this by artificial intelligence, it only takes 1 second for the AI to extract the key elements for pneumonia decision-making from the image itself. Next click. We've also gotten rid of the issue with free text, where whether it's clinicians or an NLP program, there are errors in critical element extraction. Next click. And then, of course, an AI program is completely consistent. It doesn't get tired in the middle of the night or on weekends. And so it's highly consistent. And in the paper you see referenced there, we showed that the program, which we call CheckCD, it's from Stanford University's group, performs better than natural language processing of radiology reports and is comparable to a radiologist in terms of the findings. Next slide. Well, this is a heat map of the way the CheckCD model works. You can see there's an abnormality in the chest X-ray next to the heart on the left side, and it zeroes in on this and gives a 0 to 1 probability of pneumonia that feeds right into the eudaimonia tool. Next slide. So after a lull, when we finished doing the study, we set up electronic monitoring of e-pneumonia use by Intermountain's Office of Patient Experience. There's a link that only works if you're within the Intermountain firewall that is available to emergency department leadership, both system-wide and at the individual emergency departments. And then each clinician can look at their own results. This is driven by Department of Emergency Medicine leadership. With the results that I showed you, we had a strong push that this becomes standard of care throughout our hospitals. And we were doing this really up almost to now with having to have individual review of X-ray reports and discharge codes. But we recently have automated that because we're using the J18X discharge codes, and CheckCD is providing the radiographic pneumonia information. Next slide. So this is an example. The light blue is just blanking out some of the information that can't go outside of Intermountain. If you look at the run chart at the top here, you can see that there is a gradual increase in utilization. We had a fall off after we no longer had our nurse educator going around to the emergency departments. During COVID, everybody's attention was elsewhere, but we're back up to about 60-65% utilization of e-pneumonia by our frontline clinicians, and we hope to drive that further. Interestingly, there are significant differences by different groups. And again, our small rural hospitals tend to be a little bit lower, although there are some exceptions to this. Next slide. So we are now extending e-pneumonia based on our work now for a dozen years. We have an ARC grant to adapt e-pneumonia from the emergency department to 28 Intermountain urgent care clinics, which are affiliated in our vertically integrated nonprofit healthcare system. We're currently in year 4 and have deployed e-pneumonia into the urgent care clinics at Intermountain. We also are developing smart and fire e-pneumonia. Currently, e-pneumonia runs only within the Cerner electronic health record, but we received a grant to develop this as a smart and fire application that is interoperable with different electronic health records. We're developing a new user interface for Epic in conjunction with our team at Vanderbilt. And we're also developing a new patient-centered feature to support shared decision-making regarding the site of care. And we've just about 3 months into this with our great partners, Stanford and Vanderbilt. Next slide. For the urgent care clinics, we had to develop new user interfaces and new Bayesian probabilistic models because the patient population, the workflow, the physicians are quite different than in emergency departments. One of the issues in our urgent care clinics was that a fair number of patients were being diagnosed with pneumonia without getting a chest X-ray to document whether or not we have actual pneumonia that is evident on the X-ray. And so there's an AI model. Actually, we're still tweaking that. I think it goes into production next week, where there'll be an alert, an interface recommending chest X-ray ordering. And this uses an AI model that uses the different factors there on the slide. And then again, CheckCD. CheckCD was updated and trained in the upright and lateral films, upright PA and lateral films that are done in these Instacares, and combined with additional data elements to calculate a % likelihood of pneumonia. The urgent care clinics have much less data obtained on patients than emergency departments, so we had to redo the AI for this. And then we're getting giving the clinicians a little bit of time to get used to all of this. But then we're going to put in an alert that we already have ready to go that will display if the clinician enters a pneumonia diagnostic code and they didn't order an X-ray or the check CD didn't detect pneumonia on the film, again, to drive use of e-pneumonia and use of the logic that you have to have X-ray evidence to call it pneumonia. And we presented this earlier this year at American Thoracic Society. Next slide. The e-pneumonia for the Instacares, we also had to do some redoing of our criteria for hospital admission. So patients who have low oxygen saturation, a significant pleural effusion, and then you can see yet another AI model, Bayesian probabilistic model that Peter Haug, who's on this call, has developed for us using the different factors that are available in the urgent care clinics. Next slide. So that's my ending slide. I'm the lead on this, but absolutely have a partnership with a number of physicians across Intermountain, nurses, pharmacists, respiratory therapists, and then the informatics developers who are on here, Catherine Cutler and Peter Haug particularly. And then we have a database team. And this is a beautiful picture of Intermountain Medical Center late in the day. And also, I guess I'll just say one additional thing. After having heard the first part of this, Utah is a population that is quite different demographically and in terms of ethnic diversity compared to Nashville, Tennessee. And so one of the things we're very interested in doing is trialing e-pneumonia, deploying it in a very different clinical environment with different patient population. The information we've looked at so far shows that our tool performs very well in different ages, gender, and ethnicities where we've tried it. But we're very interested in how it works in Nashville, Tennessee. So as you can tell from this, I'm a clinician, and I know there are a lot of people here who would like to know what happens behind the curtain. We show screens just like I showed you there to the clinicians, but Catherine Cutler and Peter Haug and their team are the ones doing all the work behind this. And I invited Catherine to tell you briefly what the technical side of e-pneumonia clinical decision support is.
Do we have time to do that, Allison, or do we need to wait for Q&A?
I'd say since you're on now, you could just do it quickly. And then if we have questions later, we can answer them then.
All right. So Peter and I presented this work at HIMSS this year we talked about how we can improve patient care by real-time interoperable decision support. So just keep in mind that this is real-time, and to the second, we're able to do this functionality external to the EHR, and our technical teams have built an infrastructure to integrate with the Cerner EHR, and now we're building it to integrate with the Epic EHR at Vanderbilt. The infrastructure includes four components, namely a real-time data publish and subscribe mechanism. So the mechanism subscribes to data from the EHR, and then those notifications are received into our this infrastructure and sent to a standards-based workflow engine, which uses business process model and notation, or BPMN, to be able to take the data as they are received or as they are entered into the EHR through this workflow, which would include sending it off to an AI mechanism. We have as Dr. Dean mentioned, we have the checks ED algorithm receipt, which we have from Stanford, that uses a deep neural network or a complex neural network. And we then also have Bayesian networks that Dr. Peter Haug, who's also on this call, has built for the various AI machine learning algorithms. We also then using this, Peter's just joined us, that's great. And we also have the ability to then both read data using a FHIR proxy layer from the EHR, and then also write data back into the EHR where it can then be consumed and used for clinical decision support. We use a passive alerting. It's always preferred to a in-your-face open chart alert. And so we use passive alerting to be able to notify the clinician when there's when they need to order a chest X-ray for the patient, when we believe that there's a high probability of pneumonia. And we also use it to notify them where they should disposition the patient, whether it be to home or to the hospital, or in the case of the ED, also to the ICU. So those are some of the components. Happy to answer questions later on during the Q&A. And I want to make sure we have time for Ken.
All right. Thank you to the ePneumonia team. And now we will transition. Thank you, Catherine, and for your presentation about the ePneumonia project, and to the rest of the ePneumonia team. And now we will transition to Dr. Ken Kawamoto for his presentation.
Thank you. And sorry, I was in the bathroom because I thought we were going to start a little bit later. So apologies for that. Thank you for adjusting. Okay, so I'm going to describe a project also in the pulmonary space, but in the ambulatory setting for improving lung cancer screening through an EHR integrated everyday shared decision-making tool, a Smart on FHIR app, and clinician-facing prompts. I have the ARC logos here because ARC is funding us, and I also presented on this for an ARC webinar recently. Next slide, please. Disclosures. So outside of this work, I have honorary consulting, sponsored research, writing assistance, licensing, or co-development with a number of organizations, but have no conflicts with any direct relevance to this work. And the tool I'm describing is available for free. And this was, again, made possible by ARC. Next slide, please. So the clinical need we addressed in this work is improved lung cancer screening. So a lot of other cancers get more attention, but lung cancer is the #1 cause of cancer deaths in the US and actually worldwide for both men and women. It leads to has more preventable deaths compared to any other preventable and widely screened cancers. Lung cancer screening with low-dose CT scans has been shown to reduce lung cancer screens by 20% or more. So fairly substantial, quite effective test. And the US Preventive Services Task Force has recommended offering screening to high-risk patients. That's older patients with a history of heavy smoking for 10 years now, so quite a long time. At the same time, the vast majority of eligible patients in the US are not screened. In 2020, this was estimated about 6.5% of eligible patients were screened nationwide, so less than 1 in 10. And at that point in Utah, it was less than 2%, or less than 1 in 50. Next slide, please. So why is it, right? In a lot of healthcare, we don't do as good a job as we should, but less than 10% rate seems particularly bad. So this includes lack of familiarity with eligibility criteria and insurance coverage. It includes difficulty identifying eligible patients. It includes challenges include the need for guidance on managing screening results. There is also some skepticism by some folks about benefits of screening. And a key part where we spent a lot of our effort in this project was insufficient time or knowledge to conduct shared decision-making. Why is shared decision-making important in the first place here? There's a lot of potential downsides that you can have from something like lung cancer screening, because if you find something that you want to follow up, you oftentimes will get a biopsy, and that can have some complications as well, because you're going to the lung to take tissue. There's also wide individual variation in expected benefit. So if you look at the top 20% of people at risk versus the bottom 20% in the underlying clinical trial that established the effectiveness of lung cancer screening, there's about a 60-fold difference in risk levels for those patients. So obviously pretty different importance. Because of this, shared decision-making is recommended by clinical guidelines and at this point is required by CMS prior to initiating screening. And this includes the need to use a decision aid. So you can imagine how challenging this would be, for example, if every time you wanted to do breast or colorectal cancer screening, you had to use conduct shared decision-making using a decision aid and individualized risk factors. But this is what is the case for lung cancer screening. Next slide, please. So the objective was to design, develop, and evaluate a scalable approach to enabling lung cancer screening that addresses these key barriers. Next slide. So the goals in developing this intervention was to come up with an approach that integrates with routine primary care workflows because primary care is where most effective cancer prevention strategies are generally implemented. To make it easy for providers to identify patients who are eligible for lung cancer screening. To make it easy and fast for providers to conduct shared decision-making, and in particular support an approach to shared decision-making that our colleague Tanner Caverly from Michigan and a co-investigator on this project calls everyday shared decision-making, so something that can be completed within 1 to 2 minutes while moving to more what we call full shared decision-making model when the time is available, but really to try to get it to something that can be incorporated into routine primary care visits and to use an approach that can be widely scaled. Next slide, please. So in this work, we had a wonderful starting resource called Decision Precision. This is a web-based lung cancer screening shared decision-making tool, also available at screenlc.com. That was developed with VA funding by Dr. Caverly and Angie Fagerlin at University of Michigan and Ann Arbor VA. Angie is currently at the University of Utah. This was originally designed to support what we call full shared decision-making. So an extended discussion with the patient, whatnot, and the screenshot is shown here. This worked well when used by full-time lung cancer screening coordinators in the context of dedicated shared decision-making sessions at the VA. But we quickly found that this was too time-consuming to use routinely in primary care settings. We looked to support this in our health system operationally initially, and it was just not really feasible. These are very sick patients, older patients with a very significant smoking history, usually lots of comorbidities, and using this tool just didn't cut it for trying to squeeze into routine primary care visits with patients with a lot of conditions going on. Next slide, please. So we enhanced this into a Smart on Fire tool called Decision Precision Plus to support this, Decision Precision to support everyday shared decision making. So what you see in this tool, and this is what you find currently in screenlc.com, only the elements needed for everyday shared decision-making is kept on this main web page. Content relevant to full shared decision-making is moved to supplemental tabs. I'll show you in a slide coming up the various time-saving features we built in. And this is, if you use Epic, this is now incorporated in the foundation or default recommended lung cancer screening module of that EHR. Next slide, please. So this is what it looks like once we converted into a Smart on Fire application for EHR integration. This figure is taken from a chest manuscript that's available, and I'll just highlight a few of the points that are a focus of our time saving. So if you look at arrow or number 1, you can see there's one tab, personalized risk assessment, which is meant to be usable without having to go to the other tabs if you want to go through this shared decision making fairly quickly. At number 2, you can see that person figure that shows in a graphical overview where the patient fits in terms of the overall balance of benefits versus risks, whether it's preference sensitive or something that should be encouraged. And in some cases, we do discourage it, for example, with low estimated life expectancy. With number 3, you can see there's a button that says document shared decision making. That's where we can auto generate billing compliant documentation of the discussion. 4 is a quick script for shared decision making. 5 just shows that this is a tab in the EHR, as you can see here. 6 is where you can see the overview of the auto pulled in data. We pull in about 2 dozen features. 7 shows a one-click ordering capability, and 8 shows buttons you can press to say, hey, this is what the patient decided, and cascades down to all the downstream EHR workflows. Next slide, please. We did try to put in a fair amount of prompts for lung cancer screening discussion, including use of this tool. In the Epic EHR, you can see with the where it says 1, the care gaps that the patient has is shown. This includes the 1 second from the bottom that says, hey, lung cancer screening discussion is indicated. This is reviewable also in the health maintenance tab. It's number 2. With number 3 showing the topic, with number 4 showing hover over information, talking about the need for screening and the need to and suggestion to use this application. Next slide, please. Here's another prompt in the ordering for lung cancer screening. You can see number 1, we note that the CMS requires documentation shared decision making. So this is fairly smart. And only triggers when we detect that this is an initiation of screening and therefore subject to this billing requirement. And then number 2 shows generic instructions on when to consider lung cancer screening and the billing related requirements around conducting shared and documenting shared decision making. Next slide, please. So as I mentioned, this is something that's been in use at the University of Utah. We've conducted a pragmatic clinical trial. The setting is primary care and pulmonary clinics. We intervene with these, what I just showed you, EHR prompts and an EHR integrated everyday shared decision-making tool. This was a pre-post design. We couldn't randomize because the health maintenance module in Epic doesn't allow for randomization in terms of deployment. The methods we used, we focused on primary care patients who met the 2013 USPSTF criteria. This has been recently updated to be more inclusive. With no chest CT in the past year, who had not declined screening the last 3 years. So people who really should have gotten discussion and potential lung cancer screening. The primary outcomes we looked for here was lung cancer screening ordering completion, and we conducted logistic regression. Next slide, please. So results, we included about 1,500 patients. Low-dose CT ordering increased from 7% in the baseline period to 27%, so about a 4-fold increase with an adjusted odds ratio of about 5. Low-dose CT completion increased from 4.4 to 17.7%. Interestingly, though, we found that SDM tool use prior to the low-dose CT ordering was only for about a quarter of patients, and I'll discuss that a little bit later. Next slide, please. This shows the ordering and completion rates stratified by the expected benefit from screening, where we looked at folks who we considered based on modeling to be particularly high benefit versus more intermediate benefit. You can see the ordering rate increased for both, as did the completion rate for screening, but there did seem to be a trend towards increased screening for patients particularly at higher benefit. Next slide, please. Okay, so just in summary, introduction of an EHR integrated everyday shared decision-making tool and provider prompts was associated with significantly increased lung cancer screening ordering and completion at a single health system. The SDM tool was used about 25% of the time prior to initiating screening. So this certainly is suboptimal, but when you look, it's still higher than many previously reported shared decision-making and shared decision-making tool use rates in primary care settings, including for lung cancer screening. And I think the conclusion here, and we have talked to folks and whatnot, also is that even a few minutes just may be too much to add to busy primary care workflows for patients with this demographic in particular, patients who have a lot of conditions requiring attention. Next slide, please. Based on this, we have a current research focus enabled by a follow-on ARC grant. Here, what we're looking at is evaluating first replicable approaches to real-world dissemination and implementation of interoperable decision support tools, including what I showed. Decision Precision Plus is available for free for integration with any EHR, and we do have multiple implementations underway, and we do provide free integration support. So if you're interested, please contact us at reimaginehrutah.edu. And we're also designing, developing, and evaluating interventions to directly engage patients and overcome some of these persistent barriers to lung cancer screening. The first is My Lung Health. It's a free patient-facing Smart on Fire app that's integrated with the personal health record to educate and activate patients so that we don't rely on providers initiating the discussion in order to let patients know about lung cancer screening. We are evaluating via patient randomized trial here at NYU, and we'll also be sharing this for free following validation. Next slide, please. For more information, you can use Decision Precision at screenlc.com. We maintain that site as well. And for Decision Precision Plus, please do email us if you think you might be interested. As I noted, the first phase of this clinical trial is published in CHEST. We're working on a follow-on publication that looks at a secondary phase where we also added in simple patient-facing prompts. And you can learn more about our Reimagine EHR initiative, which has built, I think at this point, maybe about a dozen of these applications and have deployed them into clinical care. And you can learn about that at this Jamie Open location. Next slide. So that's it. Thank you. And if there's time, would love to go into Q&A with our sessions.
Thank you, Ken. And we do have just a few minutes where if there were some audience questions, we could get those answered. So feel free to put your questions in the Q&A. While we wait to see if a question comes in, I know that it looked like Peter maybe wanted to make a comment earlier about the pneumonia tool. So if he wanted to do that, feel free.
Yes. Well, thank you. I guess the main comment I would make is that our goal with these applications, and we have a number of them planned or underway. Our goal is obviously both to create an environment where it's relatively easy to build consistent, high quality decision support tools. And we sort of align the consistency part with being able to figure out and then match using appropriate tools the workflow that's needed for a particular problem. And then the AI comes in when you get to the high quality part. It's through all the various forms of AI, obviously not just the fancy stuff like image interpretation, but in addition, all of the classic decision support with rule-based and mathematical models that we do. But I think those are the two goals and the two tools we like to think about. Consistency is workflow and standardized workflow, and quality is using the artificial intelligence components that we've been developing or working with others to develop. So thanks.
Yeah, thank you. And then one of the questions that I was thinking about in regards to both these tools was if they can be adapted to other health conditions. So can the basic format of the tool be used or repurposed for another condition?
So I can comment on that. We had the opportunity to work on pneumonia for a period of time, and then it was very interesting. We needed to work on a sepsis predictive model. We've been asked because the one in the EHR was not proving as predictive as we would like, and so we redesigned this to be able to use for sepsis, and we brought it forth very quickly. And it's in production as well. And so we're very pleased with the reusability of this infrastructure and look forward to many more models. I know Peter and I have been working on a mental health integration as well as pulmonary embolism. And so we have lots of opportunities to, we actually have a whole queue of different conditions that from which we can work.
Yeah, that's really exciting. Ken, what about your tool?
Yeah, so the approach certainly could be replicated. We have an AMIA presentation for folks come in where we're describing our architectural pattern called Simple to implement these kinds of applications. For the lung cancer screening app, it would require right there. We're not using a framework where we're just plugging in numbers. So it would require adaptation for use in a different system. As we've developed quite a fair number of these applications, we've started to get concerned about not only how do we replicate, but how to avoid app fatigue, right? With like, here's an app for every little thing that you need to do. So we've started to move towards a consolidated model of creating the notion of a Uber framework for, not Uber the rideshare, but like, you know, encompassing framework for this kind of thing. For the outpatient type of context, we've created a platform called Disease Manager that calls, and you can embed apps like this inside it, and that is highly configurable, and that we can use natural language-based rule specifications to pop up new modules without any coding. So we have definitely started moving to that. And I do think an interesting question as we go from, can we build these kind of applications and have effect, to how do we really scale this, not only across sites, but in terms of all the different conditions we could use these kind of applications for. I think it's trying to figure out how to do this in a way that it doesn't become like medication alerts, where initial studies showed how absolutely effective they were. And then we built like 10,000 more of those, and then people start ignoring all of them. So I think that's a really interesting research question as well.
I think it goes with what Dr. Pinchina from Duke said earlier in the session, and wherein he said that it has to be translated into the workflow. It's essential that the decision support or AI or whatever component we're trying, it's in the normal clinical workflow. So whether we're building an Uber structure, as Ken said, or whether we are just incorporating into the normal workflow, it's just anything to prompt or the clinician to do the right thing. That's what we're aiming for.
Excellent. That sounds really great. And I think that we need to move along to the next and final part of our session today. But if anyone else in the audience did have questions about these presentations, feel free to put those in the chat, and they will get those answered for you. And so I will now transition over to Lolita to introduce the final part of our presentation today.
Thanks, Allison, and thanks to our wonderful speakers so far today. We've reached our final session on the agenda of the CDS workshop series, and we have another set of informative presentations. This panel will focus on measuring and evaluation successes in CDS development. Our speakers for the panel today include Wes Sargent with CDC's National Center for Injury Prevention and Control, Karen Nanji from Harvard Medical School, and Allison McCoy from Vanderbilt University Medical Center. Just a reminder for the audience that you can use the Q&A feature at the bottom of your Zoom screen to submit any questions. And if you have any general comments, feel free to add those into the chat as we go through the presentation. I'll now turn it over to Wes from CDC to start us off.
Thank you, Lolita. Good afternoon. And you can move it to the next slide. And yes, I work within the Injury Center in the Division of Overdose Prevention, and I sit specifically within the Health Systems Research Branch, which is where our guideline work, so the guideline for prescribing opioids, and where our health IT interventions also reside. So work exclusively with translation, dissemination, implementation of the 2022 clinical practice guideline, And then I'll go over very briefly 3 strategies or health system interventions and then I'll focus on clinical decision support. Next slide, please. So this is CDC strategic priorities on how we address the overdose crisis. If you look in here, I won't go over every bucket or every area within this, but specifically where our work within the health systems is equipping clinicians, health systems, payers, and employers. So we know that the clinicians in the health systems are crucial with promoting safer opioid prescribing and to be able to manage for more effective, equitable pain management, both with adults and youth. And we're focusing in on providing evidence-based treatment for substance use disorders, particularly those that are disproportionately affected populations. This is also with the health systems work. This is where we're able to implement guideline concordant care, specifically with quality improvement measures that we've developed to align with the 12 guideline recommendations. Also building out clinical decision support tools, being able to equip clinicians with the tools, resources, guidance they need to be able to support care coordination and be able to manage pain. So again, that's where this guideline work and the health systems interventions resides. So next slide, please. And so we know that health systems have the potential to improve pain management, which includes being, safer use of opioids, being able to prescribe appropriately, ensuring that patients have the proper pain management they need for pain. And we're able to do this guideline concordant care through a broad scale by working with the health systems. And so the first real area that we focused in on starting around 2015, 2016 was around integrating prescription drug monitoring program data into clinical workflow and then building out additional data. So for example, now integrating non-fatal overdose within the integrated PD&P EHR interface. And as we've been working now, moving from 2016 on now to our current cooperative agreement where we fund states, cities, and counties with overdose data to action, we started working around integrating quality improvement measures, developing those. As I said, there's 16 measures that we've developed that align to the 12 guideline recommendations. This allows systems, clinical practices, the ability to be able to track prescribing patterns, and also being able to screen for substance use, opioid use disorder, linkage to care, retention to care. And then last, where we've been working with Office of the National Coordinator with ONC and Ken and Bren and several others that are on these calls is now integrating guideline concordant care into clinical decision support tools. We started with the 2016 guideline and now working on piloting this with the 2022 clinical practice guideline. So next slide, please. And so what I want to do is just really quickly just go over a recent evaluation where we worked with 4 health systems. Where we found a lot of success is developing collaboratives. And that's one piece that we've been encouraging with our local overdose data to action cooperative agreement where we're funding cities and counties. So one of the strategies within there is working with clinicians and health systems. And so being able to build this out as a collaborative, we found to be very effective with quality improvement collaboratives and CDS collaboratives. With this collaborative or this pilot, we worked with 4 health systems. You can see one in Kansas, one in Texas, one in New York City, and one in Pennsylvania. And what we evaluated was pre and post, and we used the 16 quality improvement measures to evaluate this. And also we interviewed the project champions and the IT leads within all participating with all 4 health systems. Next slide, please. And so each system chose, not all systems, well, let me take that back. The system in Texas did implement all 12 guideline recommendations or CDS tools. Not every system did do this. And it was built out, the system in Texas built this out using Epic, and the other 3 systems all ended up using Epic as well. And this did help because they were able, since they took the lead to build out and integrate all 12 CDS tools, they uploaded it into Epic User Web, and the other 3 systems were then able to download it and adapt it to meet either their state or health system policies. They aligned to the guideline, but they might have configured it to meet some of the other policies that the health systems or the states might have implemented as well. So they were able to refine it to meet their needs. So there was several alerts. They could, they could adopt that and build in snooze features if they wanted to. They had access to PDMP data. This was mainly done through another proprietary software to be able to integrate the PDMP data. Some systems built out registries to be able to track over time. And these were all built as smart sets, again, using Epic. And there are additional tools, clinical notes, referrals. And then also, importantly too, with guideline or with recommendation 12, also the ability to screen for substance use opioid use disorder. All right, next slide, please. Next slide. So very quickly, just if you can go back one more, sorry. There we go. So just these are just a few of the results. I have a link where you can go in to at the very end, and you can go look at more details. We have this posted on our website too, within our DOP, Division of Overdose Prevention website. But these are just some of the results I just wanted to highlight. So the number of patients that were being counseled around opioid risk and benefits increased. You saw that short-term follow-up increased. The use of immediate release opioids when obtaining a new opioid prescription increased. Urine drug testing increased as well. You see that naloxone counseling, co-prescribing naloxone with higher levels of MME when that's being prescribed, that increased by 6-fold. And the use of being able to query the PDMP within clinical workflow before prescribing as well increased. So next slide, please. Next slide. Yeah. Okay. So really quickly, just some lessons learned. The development and implementation of CDS tools, the ones that align with the CDC guideline, do indicate to show potential to promote safer opioid prescribing and improve patient care. The design, validation, implementation process for CDS tools can be highly variable. This did take a long time to get off the ground. Healthcare systems capabilities and resources are very critical. Some of the successes of this really lied with the health system in Texas that was able to go ahead and already implement all the CDS tools and be able to share those tools through Epic User Web. So that was, and I don't know what happened to the slides, but it looks like it disappeared. If you can add those back. All right. But that was very critical. And one of the particular pieces that was very important with the Texas system is they had hired staff that had trained at Epic, and so they were able to directly build and revise and refine the EHRs themselves. And so that was huge. It could be very expensive if you have to go through Epic and use their developer, or any, not just Epic, any EHR developer. So being able to have the in-house capability of that really did help facilitate this and allowed the collaborative to be successful. And then flexibility with the tools. Every system really did take a agile kind of iterative process. And so patience was a big deal as well. Next slide, please. And I think I've already highlighted this, but yes, in-house expertise, as I mentioned, the flexibility, shared learning, that's really critical with the collaborative of having those 4 systems to support each other. The systems met bi-monthly, so they met throughout the year, and they were all available. So if they needed to hop on a call, that was helpful. So barriers, as I mentioned, limited resources, not having the internal expertise, as I highlighted, that was very critical to helping make this success. So next slide, please. And just wanted to thank our partners that we're working with right now. As I said, we're working on encouraging uptake and use of the 2022 clinical practice guideline. We're updating the previous CDS that aligned to the 2016. So now piloting the revised 2022 CDS tools. Right now, current contributors, ONC, Medical University of South Carolina, Yale, University of Washington, Security Risk Solutions. And as I said, we're continuing to refine and develop these CDS tools. Next slide, please. And I wanted to highlight at the very end this resource that we worked with ONC on. There's this integration framework. One piece I wanted to highlight the most is the toolkit at the end. So we worked with a series of systems on integrating PDMP data into clinical workflow, but also implementing the CDS tools that I just described. And the toolkit at the end has a quick start guide, integration taxonomy, training guidance, auditing guidance. I think more importantly, MOUs that health systems were able to use to implement this type of work. So that could be a huge success right there, already having an MOU ready to go that's health systems have successfully executed to be able to integrate multiple data streams within the integrated interface. And then last, it has some testing guidance and testing templates as well. Again, there's some links here. There's links at the very end as well, where you can read about additional health system successes with implementing CDS tools. And here's some of the anecdotes from the PIs and physicians and informaticists that implemented this work. And I believe that's it. I think the last slide is just some additional links. So thank you.
Final presenter for the session, Allison McCoy.
Thank you. So I'm sharing slides.
Yeah, could we please get the slide deck back up? Thank you.
Great. So I'm Allison McCoy. I'm faculty in our Department of Biomedical Informatics at Vanderbilt University, and I direct the Clinical Informatics core at Vanderbilt. And I'm excited to talk about a few different clinical decision support measurement projects that I've had the opportunity to work on. Next slide. So first I want to share some work that I did with ARC and NORC with the Clinical Decision Support Innovation Collaborative. And I co-led the scaling, measurement, and dissemination of CDS projects with Jerry Osheroff. So next slide. So we had 3 different products that we were responsible for disseminating, but what I'm going to talk to you now about today is the Patient-Centered Clinical Decision Support Performance Measurement Guide. Next slide. So this product was designed to describe performance measured for specifically patient-centered clinical decision support to help users understand both what they should measure and how they should measure it, depending on what the goals of their intervention are. So whether or not they were looking to complete a formative or summative evaluation, and then who they are. So are they a researcher looking to publish on their work? Are they a health system leader? Are they a vendor trying to make sure that, you know, their product supports these needs? And this product had sort of 3 main focuses. So we had the actual measures for evaluating PCCDS. We presented user scenarios to help support the utility of our measures. And then we had a call to action with gaps and recommendations. Next slide. So we had 3 different or sort of ways we organized the measures in the guides. So the first types of measures we included were what did you design? So did you use sort of a user-based design? What were some of the organizational factors that went into your design? We listed out what was used as far as the CDS. So what was the adoption of your intervention? How often was it used? Did you do any kind of workflow analysis? And then what were the results of this intervention? So things like satisfaction, We looked at clinical guideline adherence and other measures for the knowledge and decision-making quality, collaboration and workflow measures, and cost of the CDS intervention. And I want to highlight here, we specifically did not focus on outcomes-related measures. There was a separate work group for objectives and outcomes, and they put together their own measures for outcomes of the CDS. So those are not covered here. Next slide. So this is a sample of the measurement inventory, and the QR code I have on here will take you to the full inventory up on the website. But this is just some examples. The team did a really amazing job putting together all these measures. In total, we had over 170 across different areas for patient and caregiver and clinical care team perspectives. Next slide. So some of the key findings as we put all of this together, most of the measure subdomains were in CDS design, satisfaction with the CDS tool, use frequency, and users of the CDS. Some of the constructs that we frequently identified were usability, alert fatigue, adoption, clinical guideline adherence. And then most of the settings were in the primary care, inpatient, in emergency department settings. Next slide. We did find a lot of gaps as we were putting together this inventory. So we tried to focus on patient-centered measures, but most of these were sort of related into some of the assessing the development and implementation of the CDS interventions, not so much focused on the clinical care team perspective. Not a lot of measures captured the feasibility, fairness, and equity and standards. And then we needed standardized measures for patient knowledge, patient-informed choice, cognitive workload, alert fatigue, and acceptance. Most of the evidence that we found was either low quality or at high risk of bias in our review. So there's more work needed on that. And most of the focus was on technical feasibility without as much emphasis on socio-technical aspects of the intervention. We can go to the next slide. So next I want to talk about some of the work that I've had the opportunity to do at Vanderbilt and with some of my colleagues here. Next slide. So we have tried to do a lot of work in evaluating our clinical decision support at Vanderbilt. We've sort of started with some tools that we've developed locally. So this is a Tableau dashboard that we, some of my colleagues at the Brigham developed, and then we implemented it here. So it's now running in a couple of different sites. And what's exciting is that this helps us measure a lot of important qualities about our own CDS. But if we go to the next slide, this is actually a version that looks very similar to the dashboard that we created that Epic has now implemented into their foundation system to enable researchers and operational leaders across all institutions to help measure some of their clinical decision support. Next slide. We are also using a lot of different advanced artificial intelligence approaches for measuring our CDS. So this is some work that Adam Wright initially did at Brigham, but has brought it here to Vanderbilt. So we are running some machine learning methods to look for malfunctions in our CDS. So sometimes the alerts that we put in stop working for various reasons. Maybe the lab results behind them change, or other things happen. And so we are running these automated approaches to help identify when things stop working in our CDS. Next slide. This is again some work that Adam Wright initially did at Brigham, but has also brought to Vanderbilt. So we look for cranky comments. Anytime a clinician overrides an alert, they have the opportunity to put in comments with their override. And often we have found that if there are swear words or already or again or different keywords in those comments, it tends to indicate that the alert is not working as we expected. So most of the time when we see those cranky comments, we can go in and review the alert logic, Often we found that, there's something that we can fix to make the alert work better. So that's something we have implemented. And then next slide. This is some more recent work that Siri Liu, one of our other faculty members at Vanderbilt, has put together. So we have been using ChatGPT and large language models to evaluate our alerts and find ways that we can make our alerts more specific so that we can reduce our override rates and improve our outcomes related to the CDS. Next slide. So sort of with both of these projects combined, we feel like there's a few critical gaps in CDS measurement and sort of some opportunities for funding and future work to overcome these gaps. So the first is that there's no standard set of measures for comprehensive, reproducible, accurate CDS measurement. So when we look at our PC-CDS inventory and some of the approaches that we've done with our own CDS, everyone's measuring our alerts differently. So do we look at the firing rate? Do we look at the override rate or the action rate? Depending on how you measure it, your outcomes may be different, and it's hard to really reproduce your findings and compare across institutions. Next. We have also found that a lot of EHRs don't provide appropriate or easy access to data or tools for effective CDS measurement. We've been fortunate that Epic has been really great in working with us and helping us get that data and adopting some of the findings that we have disseminated. But this isn't the case for all EHRs. And so it seems like an important opportunity to make sure that in order to effectively measure our CDS, all EHRs provide these capabilities. And then next. We also found that there are not great benchmarks for comparing CDS measures across organizations, partly due to the lack of standard measures, partly due to maybe not everyone sharing these measures, but knowing sort of what are other institutions doing, how are they performing, what should we strive for would be a great step for it. Next slide. And with that, I think we are ready for questions. Thank you.
Great, thank you, Allison. And thanks to all of our speakers. We'll now move into our question and answer portion. And just a reminder for our audience to please submit any questions you have into the Q&A feature. And while we wait for those to come in, we do have about 10 minutes for Q&A. I do have some questions to ask our panelists from this session. And I'll start with just general overarching questions, then I have some specific ones, and if anyone can answer them if you have a response. So my first question is, what do you tend to see as the key contributing factors for those who are achieving successful and impactful CDS, particularly in the use cases you've talked about?
I could start with that. I think one of the key success factors for us was to really incorporate a user-centered design process from the beginning. We sought clinician feedback at every stage, from the algorithm development to the user interface, what types of things they wanted to get alerted for versus not. And I feel that helps the clinicians get much more involved and invested in the process, and ultimately accept the technology at the end. When we have technologies that come in and the users, the clinicians haven't really been involved and they don't like certain aspects, it can be really tricky to get their acceptance, and there can be a lot of workarounds, et cetera. So for us, at least, the user-centered design process was critical.
Yeah, I would agree with that. I think that's a great point. Most of our really successful CDS interventions, we have spent a lot of time not just talking to our users who, not just the ones who request the alert, but the ones that are going to be interacting with the decision support. And then we go and watch them use the EHR as much as we can, so what screens are they looking at? How long are they looking at them? making sure that anything we are developing truly fits into their workflow so that it can impact care.
And just from talking with some of the systems, some of the other facilitators that they've mentioned as well, was having like a multidisciplinary opioid work group as well, and having identified champions and implementation leads within that. So, I mean, having like an addiction medicine person working with recommendation 12, that was very helpful. So, and then I think those are some of the other ones. And I'd already mentioned having a shared learning with other systems, the collaborative. But it's very critical, at least from our standpoint of implementing the pilots, having these champions and implementation leads and bringing in a multidisciplinary team work group.
Yeah, thanks, Wes. And I guess to build off that response, for some of our audience members who might not be evaluation experts and work at clinical settings or are at the health IT developer level, who should they bring to the table to evaluate the CDS that they're building? And Wes, you may have started to allude to some of those stakeholders.
Yeah, I think it's, again, having the champion doing the work up front, because the health systems, I mean, because of the data, it's their data, they're going to need to be able to go in there and be able to evaluate that and be able to pull it in. And so, I mean, a lot of it is planning, having the evaluation planned. If they're pulling in other data sets, the MOUs that are in place. And so from my standpoint, being outside in, I've got to work with them within the health system, making sure that they have everything they need to support. So.
Yeah, I would think.
Go ahead.
We have a fairly interdisciplinary team, so you know, some analytical support to help look at the data, research support to understand how to effectively study. You know, we can't just make a change and look at it before and after. What are some of the other confounding scenarios we need to consider? Users who are using the tool and have an interest in whatever outcome we're studying are all important in the discussion.
Yeah, I agree. And I think you specifically mentioned, you know, for people who may not be a clinician, may not even be at a hospital, there might be, you know, technology developers. I think it's critical for them to partner with a clinical site to be able to get that input and, you know, not go too far along in the design process to have, you know, fully developed product before they bring in a clinical site. I think it's really important to get that feedback early on.
Yeah, thank you. All right, my next question is specific to Karen from your demo of the guided OR, which was really great to see that video and really see the workflow. I just wanted to know, how have you seen this working at other sites? Have you seen the same impact as in Mass Gen and the same user satisfaction and usability?
Yeah, so that's a great question. We're in the process of implementing at additional sites, both within the Mass General Brigham system and around the country. We don't have the data yet to be able to do the full comparison. We have much more complete data from MGH, but so far we've had great feedback. The clinicians, I think, because we use this user-centered design process, and we really took advantage of that with all the feedback, et cetera. I think that even though there's a lot of workflow change involved in this technology with introducing the barcode scan, the efficiency benefits and the safety net, the feeling of having that safety net, all of those things are really apparent to clinicians at all of the sites, and they really see the value of receiving that information before they administer the medication, that it will help them to prevent an error.
Yeah, and one more question. Allison mentioned in her presentation that there's limited EHR data to use in the evaluation of CDS. So just overall, want to hear from you all and how you choose what to measure given that limitation.
Is that I can start with that.
Sure.
Yeah, so how do we choose what to measure? So for our software, our clinical decision support is very focused on medication errors. So ideally, we want to measure medication errors prevented. This can be very resource intensive to do in the operating room. It often requires observers because there are no orders placed. So we sometimes have to look for surrogates. So we may take a small subset of errors that we're looking for that we can go and pull data from the EHR to try to find those particular types of errors. We also measure additional things that we know will be important to hospitals for adoption. So unfortunately, safety benefits are not always enough in and of themselves. So we also measured efficiency. We measure cost savings. So we measure these other factors that we know will be important in adoption decisions in addition to the safety benefits.
Yeah, I would just say we're fairly fortunate that a lot of the data that we would want to measure is available with our EHR. So we try to use whatever data we have first. Karen mentioned surrogates, and we use those a lot. There are a lot of outcomes that we can't measure, but there are data on other things that are similar that we could measure. So I know one example is we've for whatever reason, CPR given to patients is not always documented in your EHR, but they typically get a dose of epi. So sometimes we'll look for that dose of epi as a surrogate for CPR.
Great, thank you. And just building off the limitation of that data availability, and Allison, you mentioned how there's gaps in patient-reported outcome-related measures, and recognizing that exists. How can we start moving from measuring clinical workflow to measuring those patient health outcomes? In addition to those surrogate measures, is there anything else? And what are the long-term impacts if that continues to be a trend of that limitation? And it's an open question to any of the panelists.
Great question. I don't know the answer.
Yeah. I'm sure it's something that the evaluation community thinks about, and those at the clinical setting as well. Okay, it doesn't look like we've received any more questions from the chat or the Q&A. So I'll just open it up if anyone has any closing remarks or any questions for each other. We have like 1 more minute left. All right, well, thanks so much. This was a great session to close out our CDS workshop series, and I'll turn it over to Allison Kemp to close us out for the day.
Thank you, Lolita. I just wanted to say thank you again to all of our presenters today and at our previous sessions this year. And we really appreciate all of the time that you've spent preparing for these presentations and the information that you've shared with the ONC CDS community. And thank you also to all of our attendees for coming to these events. And we look forward to possibly more CDS workshop sessions next year in 2024. So thank you, and everyone enjoy the rest of your days.